Introductory neuroscience and neuroinstrumentation, electromagnetic stimulation of the brain, part 2. Okay. So, in this session we shall consider transcranial DC stimulation, transcranial magnetic stimulation and electroconvulsive therapy for depression. Okay. Electroconvulsive therapy is interesting because when people think of brain stimulation, they think of ECT. So, I have decided to, and most people ask me about ECT. So, I have decided to add a section at the end to give you an idea of ECT. Okay. So, we will start with transcranial direct current stimulation, tDCS. So, here you use a very low current, 0.5 to 2 milliamps. It's constant current and it's applied directly to the head. It partially penetrates the skull and enters the brain. So, typically you have an electrode which is an electrode sponge unit. So, you have the metallic end of the cable is plugged into a carbon rubber electrode which is placed between the slits of a saline soaked sponge, and this you put on one side and then you put it on another side, and that is your tDCS stimulation. So, this non-invasive, and you can barely feel it if at all, most people can't. This non-invasive method of stimulation has been shown to modulate cortical excitability, and it produces changes for up to 40%, and that can last for between 30 to 120 minutes. It's transient. And computer modeling studies have shown that this type of stimulation can induce significant currents in the superficial cortical areas. It doesn't go deep. But anyway, we are interested in the superficial cortical areas, the gray matter, and it influences neuronal excitability without causing action potentials. This is important to note. No action potentials are produced, just the membrane potentials are modulated and changed. So, it has some limitations as with other electrical stimulation, transcranial electrical stimulation methods, and if you use such big electrodes, you can't really focus the site for electrical stimulation. So, various methods, algorithmic as well as shape of the electrodes have been proposed, and one method where people have found relative success is using smaller, for example, like here 1 centimeter arrays of high definition electrodes. tDCS is getting cumbersome over here. So, this allows some limited amount of focality. Remember, between the electrode and the brain, you have the scalp, you have the skull, you have the meninges, then you have the cerebrospinal fluid. So, all these tend to blur the stimulation signal, right. So, as far as transcranial electrical stimulation concerned, there are 4 main methods. One is we just saw transcranial direct current stimulation. You also have pulsed current stimulation where pulses of electrical stimuli. Then you have, these are DC, you can have alternating current instead of DC, and then finally you can have random noise stimulation. So, all 4 of them are well tolerated, you can't feel it, the current is very low, but mostly for our purposes we will consider transcranial direct current stimulation. So, as mentioned before, we have 2 saline soaked sponges and conductive rubber electrodes, non-conductive elastic straps, cables, and a battery powered tDCS current stimulating device seen over here. So, where do you place the electrodes? It is based on the 10-20 system for EEG electrode placement, and at least one of the units is placed on the scalp. The other one can be on the scalp or it can be at an extracephalic site, like for example the shoulder or the upper arm. Okay. So, the polarity effects in transcranial stimulation. So, electrical polarity will influence the effects on cortical excitability. So, for currents up to 1 milliamp and duration of less than 20 minutes, anodal stimulation, this positive electrode, over the motor cortex, that is in front of the central sulcus, it increases the motor evoked potential. Now, what is the motor evoked potential? We will come to in just a bit. So, opposite effects occur when the polarity is changed to cathodal stimulation. Okay. So, here you have the current source, you have the anode, you have the cathode, and the electrical stimulus enters the brain through the anode, passes through cortical, subcortical regions that we are not sure, and then it goes out to the cathode. Okay. So, what happens when you do this? A portion of the current will penetrate the brain. So it produces, most of it doesn't, okay, because as I said, all these blurring layers are in between. And when it does penetrate the brain, it would produce a field of approximately 0.3 volt per meter per milliamp of current applied. So this is very, very low compared to magnetic stimulation, which is almost 300 times as massive. But it's a sustained field. The magnetic stimulation is transitory, this is sustained. So what does it do? So these are some of the things we speculate it does. One is it modifies the transmembrane neuronal potential. Your resting membrane potential, all that's modified. It also influences the level of excitability. It influences the responsiveness to synaptic input, and it modulates the firing rate of individual neurons. However, it doesn't cause action potentials, it just modulates the firing rate. Maybe they fire faster, maybe they'll fire slower, but doesn't actually cause action potentials. So we just mentioned that. So since it's subthreshold, it does not cause action potential. And a surface anodic current and cathodic current. So just consider the anodic current first. So you have current flowing from the anode into the brain, and it causes invert current flow because of somatic depolarization of the cells, and apical dendrite hyperpolarization over here. Cathodal stimulation is the produce an outward current and resulting in opposite current flows. So here the soma are hyperpolarized and the apical dendrites are depolarized. Okay, and if you actually model it and look at the surface of the brain, what is the area activated? It's a big area. You can't really localize it. Okay, so this is the anodal area of the brain under the anode, and this is the area of the brain under the cathode where current exits. So what are the clinical applications? So 1/3 of humanity suffers from stroke. So a lot of research has been focused on stroke neurorehabilitation, and apparently motor learning enhancement occurs with this tDCS, which is useful for stroke management recovery. Another very important cognitive disorder, dysfunction, which occurs in older humans over 65 is Alzheimer's, where there's cognitive decline and typically manifests as unable to remember. Memory functions are disturbed. So tDCS has been shown to improve behavioral performance in Alzheimer's patients. Then depression. So patients with depression. Depression is endogenous. We're talking about something, a problem, not reactive where you're depressed because you don't do well in your exams or somebody is dead. This is endogenous where there is no obvious cause, but the person feels sad, and sometimes medication doesn't work. They found that tDCS helps in modulation and causes some relief. And finally, in chronic pain. Many kinds of neuropathy don't have a definitive treatment, and electrical stimulation is one of the therapies which have been considered for chronic pain. So one caveat we have to bear in mind, two actually. So although the majority of preliminary clinical results show positive outcomes, it should be noted that most cases there is no standardization of stimulation parameters. They're very variable across clinical studies. So you have to bear that in mind and choose the optimum possible parameters for your study. And also these studies typically are very small sample sizes. So for statistical testing, we need much larger sample sizes, and also they were done in homogeneous populations. So we have to do heterogeneous populations to see if these findings, this alleviation of problems occurs in everyone and it's not confined to one particular population. Okay? So we have to bear these in mind before you go ahead and start using tDCS. Transcranial magnetic stimulation. So this is a technique where you induce localized small amplitude, relatively small amplitude currents in the cortical tissue via principles of electromagnetic induction. So this is Professor Tony Barker, University of Sheffield. So he was the one who first made this transcranial magnetic stimulator at the University of Sheffield. So the pulse duration is approximately 100 microseconds, and the pulse strength is 2 Tesla, which is huge. And here you see him stimulating the right motor cortex of a subject. Now, TMS is very interesting in that you cannot perceive the stimulus. Our brains do not perceive magnetic stimuli. So it is painless. You don't know. You might have some other effects like feeling heavy in the head after much TMS stimulation, but there is no perception of the stimulus itself. So on the right you see the circuit. Essentially it's a huge capacitor bank, and it gets charged, and then it suddenly discharges through a coil which sets up a transitory very strong magnetic field. Now this magnetic field induces an opposite magnetic field, electromagnetic induction principles, in the brain. These lines of force cut through axons, and the motor cortex and the axons from the motor cortex are very fortuitously placed so that they cut it as it bends into the pyramidal tract and the spinal cord, and that's why it's very useful for eliciting motor system responses. Just for comparison, a typical TMS machine would be about 2 to 5 Tesla. As Tony Barker used 2 Tesla. Now the Earth's magnetic field is microscopic compared to this, about 30 microtesla. A refrigerator magnet is much more powerful. It's about 5 millitesla. So a rare earth magnet, these are very powerful magnets, and you should be careful. If you have 2 of them and your skin gets caught in between, it's impossible to separate it out, very difficult. So that's much higher, it's 1.25 Tesla. And then the clinical MRI systems are up to 3 Tesla, and research MRI systems can go up till 7, 10 Tesla, especially animal systems. So the magnetic field induced by the coil is quite major, but it's only it's transitory. It doesn't last for more than microseconds. So what does a TMS field look like? So this is how it looks like. So this was done in Professor Vahe Amartyan's lab, my thesis advisor in SUNY Brooklyn, and we modeled the field, and the sensor was a little 1 centimeter coaxial cable stripped at the end, and with the magnetic coil below we induced currents in the sensor, and we plotted it out, and you see that it's very sensitive to distance. If it's half a centimeter, you have a huge focal magnetic field. If it's 2 centimeters, much smaller, and if it's 5 centimeters, practically not there. Okay, a lot of the initial clinical work and translational work for TMS was done by Professor Vahe Eugene Amartyan in Brooklyn. So how do you set it up? So again, if you look on the schematic on the right, you have a magnetic coil. Now this is a slightly different magnetic coil from a round coil. It's called a figure of 8 coil or a butterfly coil, and it kind of focuses the field to one area rather than being so diffuse. So this is typically used to stimulate the brain, and it's easy to stimulate the motor cortex because it's right over here. So you can put the coil over here and you stimulate the contralateral motor cortex. Okay, and we have to move the coil a little bit to find a hotspot, and usually what we do is we use the first dorsal FDI. This is the dorsal surface of the hand, this is the interosseous muscle between these two, and we place the coil on the contralateral side, and when we see a small tremor or a twitch, that's our threshold. We know that it's at the appropriate place and we can get a motor evoked potential. So let's some definitions. The motor hotspot is defined at the scalp position at which the lowest intensity of the TMS pulse elicits a just notable a tremor or a fluctuation over here. You can actually see it, but typically we don't go aside. We record this with EMG, electromyogram. We haven't talked about it. It's very similar to ECG. In fact, it's the same thing. The the recordings are 1,000 times bigger in millivolt range compared to brain waves. So you put an electrode over there, and as soon as we see the response, then we know the coil is on the hotspot. Okay, so if you look at this image on the right, this is the motor evoked potential. So you're stimulating with a transcranial magnetic stimulus in the motor cortex, and you see this twitch over here. So this is the background EMG. There's nothing else. So here comes the stimulus, and then you have this nice response, and this is the motor evoked potential. After the response, you have a silent period, and then the background electromagnetic EMG, the background muscle activity starts again. So this is the motor evoked potential, very different from the sensory evoked potentials we talked about, because this activates the motor system. Okay. So what kinds of TMS are there? So you can have a single pulse. So a single pulse can be applied at a given intensity. The amplitude of the resulting motor evoked potential evaluates the ease at which the action potentials can pass right from the pyramidal neurons through the internal capsule, pyramidal tract, spinal cord, and to the periphery over here. So we quantify the motor threshold, and it's defined, we define this as the minimum threshold intensity that elicits a peak to peak MEP amplitude of more than 50 millivolts in the resting muscle in 5 out of 10 measurements. So this is a very empirical kind of a definition. But then most of neurophysiology is empirical. Nothing is intuitive or can be reasoned out. Alternatively, you can have paired stimuli. So two TMS stimuli very close to each other, and this can distinguish between changes in cortical, subcortical, or spinal excitability. So these are two stimuli with a very short interstimulus interval between them. Okay, what's the utility? Again, depression. So most extensive use of TMS is in clinical depression. In fact, this is used. This is the biggest use of TMS, and insurance covers it. So the left dorsolateral prefrontal cortex here is optimal for depression. So you have the patient comes for a few times, and almost like magic, the symptoms of depression lift. And we use this only in cases where the patients do not tolerate medications well. Another place where it's used, but more research, clinical research, is Parkinson's disease. And here you stimulate the premotor and motor cortices, and it increases reaction time. What happens in Parkinson's is that there's start hesitancy. To do something, it takes some time. To stop something, it takes some time. This increases the reaction time, so it offers some help. Another place where it's used is dystonia, writer's cramp. So if you keep using your hand and use it a lot, sometimes you can't, it's difficult, it's painful to use it. So again, here if you do pre-motor cortex over here, if you stimulate, this helps in patients, and it actually improves their handwriting. And stroke. So in the stroked area, with brain stimulation, you get increased plasticity. The logic being increased plasticity would help recovery. Also, you can target the opposite side because both the hemispheres are highly connected. And you inhibit the opposite side with low frequency TMS, and the ipsilateral side with the stroke, it inhibits it with transcallosal limit right across the corpus callosum. So they found some help, it helps. But again, these are in limited studies, limited populations, homogeneous populations, and they have to be applied, extended much more before it comes into regular clinical utility. However, depression treatment is now a regular clinical method using TMS. Then other, just for completion's sake, other areas where TMS is found to be useful, one is in chronic pain, and again you use motor cortex stimulation. Some people have ringing in the ears, tinnitus, without any auditory stimuli, you constantly have this ringing. So if you stimulate the auditory cortex, this is area 41, 42, Wernicke's area, but close to it, primary auditory cortex is inside this groove over here, the supratemporal brain, area 21, 22. So if you stimulate this area, apparently it helps, the ringing stops. And schizophrenia, this is a bit controversial, but after stimulation of the auditory cortex, same place over here, you seem to have decrease in hallucinations. So one of the signs, sine qua non, of schizophrenia is auditory hallucinations. A person will hear somebody talking to them, threatening them at loud volume, but there is no auditory stimulus. They're not lying, because if you do an fMRI, you will find that the auditory area is being activated. Okay. Now, whether you believe in other elements doing it, whatnot, we don't know. It could be spirits or whatever talking. That's what the patients usually say. However, it's real. They're not lying. And TMS stimulation, slow stimulation over slow low frequency stimulation over the auditory area decreases the auditory hallucinations. And there's another very interesting thing. Everybody is a genius. Okay, I'm not being facetious. There is a particular area in the brain, the left anterior temporal lobe, and if that is interfered with, okay, for a short time, you become like Shakuntala Devi. She was a person who could process a lot of numbers, and she's from Bangalore, and nobody knew how she did it. Even she wouldn't know how to do it. It was just intuitive for her. So this is seen in older people. So typically you have a grandfather and he's playing bridge, and suddenly he becomes very good at it, and he can memorize all the other people, what cards they have. And apparently it's called one kind of dementia where it affects the left anterotemporal lobe. And this causes the person's cognition to increase to a level where they're considered genius. So Professor Schneider in Australia, he actually studied this, and these were two tasks given to the subject. So here you have, on the left side, you have a bunch of ovals, and you have to estimate in a short period of time, within 5, what is the number of ovals present on the screen. And here you see the data. On the left, this is before the TMS. After the TMS, it's statistically significant, and then it comes back to normal. And these are sham controls without TMS stimulation. The other thing he did was he made them draw. So here you see the baseline drawing. It's supposed to be a horse. Vaguely looks like a horse. It could be a dog. After 10 minutes of TMS, it looks really nice. 15 minutes, really a horse. 45 minutes, again it comes back to his baseline performance. So temporarily, you can make a person's cognition ramp up, and kind of like a genius. It would be really nice to have this before competitive exams. That was TMS. Now ECT. Now some of you all might have seen this classic movie One Flew Over the Cuckoo's Nest with Jack Nicholson, where he gets on the wrong side of the nurse and he keeps getting shocked. And movies like that, and a lot of rumors and superstitions, superstitious beliefs, have given ECT a bad name. This is Electroconvulsive Therapy. Now, typically it's a procedure done under general anesthesia, okay, where electrical currents are passed through the brain, and it triggers a seizure. You have epilepsy, briefly. Now, ECT causes changes in brain chemistry that can quickly reverse the symptoms of certain health conditions. So it is a therapy of last resort. It often works when other treatments are unsuccessful, and when this full course of treatment is completed. However, it may not work for everybody. And as I said, much of the stigma attached to ECT is based on early therapies and treatments where high doses of electricity were administered without anesthesia, leading to memory loss and other serious side effects. So when it's used properly, it can provide rapid, significant improvements in severe symptoms of mental dysfunction. So severe depression, particularly when depression is accompanied by detachment from reality, psychosis, a desire to commit suicide, or a refusal to eat. Severe mania, where you're very euphoric and agitated and hyperactive, and it's a part of bipolar disorder, manic depressive illness. Catatonia, where a person is like a board, and there's totally no movement, no expression, or there may be fast, unusual, strange movements, lack of speech, and similar symptoms. And finally, agitation or aggression in people with dementia. So in all these conditions where the patient cannot be controlled with standard therapy drugs, we use ECT. So they're slightly different because, for example, you can use TMS and ECT for depression. So TMS alleviates major depression, depressive symptoms by sending electromagnetic pulses to the prefrontal cortex. ECT, you cause seizure and reset the whole brain. And TMS uses electromagnetic pulses which are similar to that of an MRI machine. And the theory is that when you stimulate the prefrontal cortex, these pulses reactivate the neurotransmitters believed to be responsible for the depressive symptoms. If you see the figure over here, this is TMS, we've gone through it. ECT, it is only done in the hospital and under general anesthesia, and a lot of things are monitored. ECG, there's an intravenous line for sedation, the blood pressure, EMG activity, stimulating electrodes, and the ECT device. Okay? So TMS is best for major depressive illness who found no relief from the first and second lines of treatment prescribed for their symptoms. And this TMS usually, is given prescribed for a period of 4 to 6 weeks, about a month. And, a coil is attached, the person goes and sits down and gets zapped in the left prefrontal cortex, and that's how it goes. So what are the side effects? Well, you have this tapping noise, and then there's a weird sensation on the scalp. But otherwise, there are no, you don't feel anything. I speak from personal experience because in my lab, I tried stimulating my brain with the TMS, motor cortex, and I could not feel it at all. But my hand, my leg, all moved by themselves. The nice thing about TMS is it's non-invasive, and about 70% of patients, they have some kind of amelioration of symptoms. They feel much better. And it's painless and non-disruptive to daily life and doesn't have very little side effects. ECT, on the other hand, is reserved for severe cases of psychosis, catatonia, or bipolar disorder. So you need the patient has to be anesthetized, which means there's got to be a cardiac tray. It can't be done even in a clinic. It has to be done in a place where you have appropriately trained mental health professionals. This is another problem with ECT. Most psychiatrists are not trained in it. I mean, they learn it during their training, but they don't actually know how to do it. So you have to go to a center which is certified for ECT. For example, in Bangalore, we go to NIMHANS. Okay? So with ECT, the patient may wake up completely disoriented, and this confusion may last for hours. In the elderly, it can last for days. So the person can't, it's not like TMS, where after TMS, it's fine, he goes home. Somebody has to be around. Okay? So that in brief is an introduction to electrical stimulation of the brain. Thank you very much.